Hello, my name's Arif Khwaja. I'm a consultant nephrologist at the Sheffield Kidney Institute. What I'm going to do in the next 20 minutes or so, or half an hour, is talk to you about the management of anemia in patients with chronic kidney disease and on dialysis. This is part of the Haemodialysis online course. So, brief outline of what I'm specifically going to talk about. I will touch upon the pathophysiology of anemia in chronic kidney disease, and then I will talk a little bit about therapies for kidney disease, including iron, erythropoietin stimulating agents, focusing on the key randomized controlled trials. I'll talk about future therapies, and then finally I will talk about the KDIGO guidelines. So, as you all know, there are multiple reasons why people with chronic kidney disease and on dialysis have anemia. One is that they're deficient of anemia because we know the kidney produces, deficient of EPO because we know that the kidney produces EPO. There is in essence, functional iron deficiency, so there is increased loss of iron, there's a reduced intake of iron, and there's a reduced ability to utilize iron. There may be deficiencies in hematinics, so B12, folate, ferritin. And then the bone marrow itself may be resistant to erythropoietin. That may be a consequence of hyperparathyroidism, which is very common in our patients on dialysis. Patients with chronic infection and inflammation similarly have that kind of resistance as well. So these are some of the factors that I've just talked about. Some of them are very easily correctable. So for example, iron deficiency we can correct if you're absolutely iron deficient. If you're B12 folate deficient, if you're hypothyroid, then that may be relatively easy to correct. I'm not sure that non-adherence is easy to correct, as the authors state here. And then the potentially correctable factors. So if somebody has chronic infection or inflammation, that may be easy to correct if you treat the underlying infective cause. If somebody's under-dialyzed, you can increase that. You can increase their dialysis prescription. That will help. And if somebody's got hyperparathyroidism, again, that is potentially treatable. PRCA stands for pure red cell aplasia, which is pretty unusual nowadays. And again, that is relatively easy to manage. Malignancy and malnutrition much more difficult to manage. And then, of course, if you have something wrong with your bone marrow, myeloma, some kind of bone marrow malignancy, then it's very difficult to correct anemia. And similarly, if you have a hemoglobinopathy such as sickle or thalassemia, that's very difficult to correct as well. So this diagram basically just shows, gives you an overview of erythropoiesis. And as you can see, what happens is you start with a pluripotent stem cell that becomes goes through a series of different maturations from a burst-forming unit erythroid cell, that's the BFU, to a colony-forming unit erythroid cell, to a proerythroblast, then an erythroblast, and then finally a non-nucleated red blood cell. And the early part of erythropoiesis is very dependent on erythropoietin, hormone secreted by the kidney, and the latter part is dependent on iron. So if you just look at that in a bit more detail, as I've said, the early part of erythropoiesis, when we're talking about the colony-forming units maturing into the proerythroblast, that's dependent on EPO. And the latter part, when the proerythrocytes become red blood cells, that's very much more dependent on iron. Hepcidin, which we'll talk about a little bit later, can inhibit the utilization of iron, and it inhibits that by reducing iron transport, iron availability, mainly by acting on this transporter protein called ferroportin. So hepcidin effectively makes you functionally iron deficient. And hepcidin levels are increased in kidney disease. And as you know, patients on dialysis have a very kind of pro-inflammatory state and have elevations of a large number of pro-inflammatory cytokines. And of these, interferon gamma, for example, acting through Fas ligand, may promote anemia by inducing apoptosis of red blood cell precursors. And then other cytokines such as TNF-alpha and interleukin-6 may upregulate hepcidin, which again will inhibit the utilisation of iron, again promoting anemia. And then finally, these pro-inflammatory cytokines themselves may have a directly inhibitory effect on erythropoietin production. So let's talk about hepcidin in a little bit more detail. So hepcidin is a factor that's produced by the liver in response to inflammation, and it works on a particular protein called ferroportin, which is very important in iron transport and iron utilisation from the duodenum and also from the reticular endothelial system from cells such as the macrophages. So if you block ferroportin, you inhibit the ability to mobilise iron from macrophages and the small bowel, so effectively leading to upregulation of, or effectively leading to sort of an iron deficient state. And hepcidin itself, the production of hepcidin is increased by inflammation, and the clearance of hepcidin is hepcidin itself is cleared by the kidney. So if you have kidney failure, you have increased levels of hepcidin. So you can see in patients on dialysis, they're not clearing hepcidin because they're on dialysis, and they're often chronically inflamed. That's all leading to increases in hepcidin, which is leading to impaired utilisation of iron. Of course, the kidney itself produces EPO, so if you've got kidney failure, you're not going to be producing EPO, and obviously you can correct that with ESA administration. But there are a whole lot of factors in uremia, whether these are cytokines or other factors that are directly suppressive on the bone marrow, so suppress the effect of EPO on the bone marrow, the response of the bone marrow to erythropoietin. So this is what hepcidin does. Its activities are inhibited by increased erythropoietic activity, but inhibited by increased erythropoietic activity, but increased by increased iron stores or by increased inflammatory cytokines. So hepcidin internalizes and degrades ferroportin, which is an iron transporter, and that stops iron from being released from the small bowel and stopped iron being released from macrophages and hepatocytes. So you effectively have reduced iron available for erythropoiesis. So let's just look a little bit about the development of anemia in CKD. Usually in CKD stages 1 and 2, the anemia is relatively mild. And then as CKD progresses, the anemia becomes a bit more pronounced. And by the time you get to dialysis, it's significant. And there is a lot of fluctuation, particularly in dialysis patients, in the hemoglobin once you're on dialysis. So let's talk a little bit about iron. We've touched a little bit about the role of hepcidin in iron, but let's talk about iron therapy. So there are a number of iron preparations that are available. There are a whole range of oral iron preparations available, and I think the two things to say about oral iron is that on the whole they are not as effective as intravenous iron in terms of raising the in terms of their ability to increase hemoglobin quickly, and sometimes can be poorly tolerable. A more recent development has been the use of this phosphate binder called ferric citrate, and that has been shown to reduce ESA requirements and iron requirements. So that's quite an interesting development. So you get two for the price of one. You get a phosphate binder on dialysis, but you can also reduce ESA and iron requirements. Now, that may not apply to all the iron binders, and I'll talk about that a little bit later. Then there are a whole lot of intravenous iron preparations that I'm sure you're familiar with. Iron sucrose, perhaps the most widely used in the dialysis units around the world. Ferric carboxymaltose or Ferinject, widely used in pre-dialysis patients, not licensed in dialysis patients, but that allows you to give a gram of iron in a very short period of time. And a more recent development has been the use of ferric pyrophosphate citrate in the dialysate itself. So this is actually this iron-containing solution within the dialysate that again has been shown to reduce iron requirements on dialysis. So what are the risks and benefits of iron? Well, there are short-term risks of iron, which is sort of increased risk of anaphylactic reactions, and they're probably mainly with iron dextran only. And then you can just have milder reactions with any iron, IV iron preparation rather than the whole anaphylaxis, just feeling a bit unwell, maybe a little bit tachycardic. And there are long-term risks which we don't know. We don't know how safe iron is over the long term and what the optimum dose of that is. And in fact, in the UK, there's a randomised controlled trial called the Pivotal Study, which is going to hopefully answer that question. But there are theoretical risks in terms of increased risk of infection. So it's always been said that giving intravenous iron may increase the risk of infection. You may get an increased risk of oxidative stress, and there is also a real risk of iron overload as well. So when we talk about iron deficiency, we can talk about absolute iron deficiency and functional iron deficiency. Absolute iron deficiency, you have low serum ferritin, less than 100 nanograms per mil, low transferrin saturations, less than 20%, and low hepcidin. And that really means that you have low levels of iron in your body stores. Functional iron deficiency, what we mean by that is that there is you've got normal or abundant levels of iron in your body, but you're unable to utilise that iron to meet demand. And in such patients, the ferritin may be normal or in fact high. The T-sats are usually low, and the hepcidin is usually high. And there's been a lot of interest in using hepcidin as a test for functional iron deficiency, but this hasn't come into clinical practice as yet. So just to revise that again, and if you're using percentage hyperchromic cells, so some of you will be working in dialysis units where perhaps they use percentage hyperchromic cells as a marker of iron deficiency. Functional iron deficiency, ferritin greater than 100, T-sats less than 20, hyperchromic red cells greater than 6%, absolute iron deficiency, very much the same, but the ferritin tends to be on the lower side, less than 100. And obviously the MCV will be low in absolute iron deficiency, whereas it will be normal in functional iron deficiency. Okay, so let's talk a little bit about iron in the dialysate. So we talked about ferric pyrophosphate citrate, or triferric, and this is a soluble non-colloidal iron salt. It's added to the bicarbonate in the dialysate, and then it crosses the dialyzer during hemodialysis treatment and binds to apotransferrin and bypasses the reticuloendothelial system. And the idea of putting iron in the dialysate is that it can replace the iron that's lost during dialysis by the trapping of blood, by bleeding, and by taking of blood. Okay. So the dialysate iron concentration of 2 micromoles per litre is thought to help maintain iron balance without leading to iron overload. So it's an interesting idea, but a little bit expensive. Does it work in clinical practice? Well, it does seem to work. So this is a control study, randomised control study, looking at the use of dialysate iron. That's in the red line here, the ferric pyrophosphate citrate, or triferric. And you can see the ESA requirements are much less than in patients who don't have the iron in placebo. These are patients on dialysis. And similarly, the amount of intravenous iron required is much less than in patients on conventional dialysis without the iron. Perhaps borderline significance in both cases, but nevertheless statistically significant. And then ferric citrate. So ferric citrate is a phosphate binder, and that's been shown to reduce phosphate. And again, in this phase 3 study, looking at its ability to bind phosphate, when you look at the anemia and iron readouts, what you can see is that patients on iron citrate had better iron parameters. They needed less intravenous iron over the course of 52 weeks than those are not on this binder. So again, that's potentially quite an interesting finding, that you could use an oral iron phosphate binder and that will reduce the real requirements for intravenous iron as well. The other oral phosphate binder that some of you may be familiar with will be Velphoro, which is again a sort of iron-based phosphate binder, and these findings haven't been replicated with that drug. partly because I think that drug is not really particularly well absorbed. Okay, so what do KDIGO say about the iron targets? Well, what KDIGO says is when you start iron, if you're ESA naive, you start iron when the ferritin is less than 500 or the TSATs are less than 30%. If you're on ESAs, again, you start the iron, intravenous iron when the ferritin is less than 500 or the TSATs are less than 30%. And if you're not on dialysis, the serum ferritin is less than 200. And they recommend that you stop iron when the ferritin rises to greater than 500 or the TSATs greater than 30%. Now, many of you who work in dialysis units will probably tolerate higher levels of ferritin and TSATs. In our own unit, we will tolerate a sort of ferritin of up to 800 and sort of TSATs of up to 40%. So there is some variation, but I would suggest that you read the KDIGO guidelines because they are the basis of iron therapy in the dialysis unit. And the other thing I would say is, as I mentioned earlier, the pivotal study, which is a UK-based study, will hopefully answer what level of iron or what level of iron dosage is safe. Okay, what about erythropoietin stimulating agents, or predominantly EPOs? Let's just talk about some of the key randomized controlled trials. Okay, so brief history of EPO. It was first isolated from human urine back in 1977, and then the gene was cloned in 1983. And very soon after the gene was cloned, the protein was manufactured, the recombinant protein was manufactured, and it was first used in a patient in 1986 and got its license for the treatment of anemia in 1990. There are a number of different erythropoietin agents that are available. The sort of first generation ones, the epoietin alpha, such as Eprex, or epoietin beta, such as Neocormin. The second generation ESAs that perhaps have a longer half-life, such as darbepoetin alpha. And the third generation ESAs, such as Mircera, which is basically a pegylated erythropoietin beta that allows continuous activation of the erythropoietin receptor. And of course, many of you will also be will be aware that there are biosimilar EPOs available now, and many of them are being used safely and effectively around the world. Sorry about this rather fuzzy slide. This just compares the half-life of various ESA therapies. You can see Mircera has very long-acting half-life that can allow sort of weekly or 2-weekly dosing, or even maybe perhaps monthly dosing. Darbepoetin has a much shorter half-life, but still significantly longer than epoietin beta or alpha. So you can imagine that if you're using the epoietins beta, alpha, or delta, you might be dosing once, twice, or up to 3 times a week. With the darbepoetin alpha and the Mircera, you'll be dosing less frequently. So how important is it to correct hemoglobin in dialysis patients? Well, this is based on observational data published quite a long time ago, showing that if you look at pure survival, the lower your hemoglobin, the less well you do. Okay, so that would suggest that if you correct the hemoglobin, people will do better. But does that actually translate into clinical practice? Well, this is a very important study. This is the US normal hematocrit study, which is a study in several hundred patients on hemodialysis who had evidence of cardiovascular disease or cardiovascular risk. That may be heart, for example, such as heart failure. And they were either randomized to either a normal hematocrit or a low hematocrit. And what you can see was that normalizing the hemoglobin to a normal hematocrit was actually associated with a higher risk of death. So even though low hemoglobins are associated with bad outcomes, that doesn't mean normalizing the hemoglobin with ESAs is associated with a good outcome, as can be seen here. And if you look at a number of other studies, not in dialysis patients, but in pre-dialysis patients, you can see a very similar effect. So there's the CREATE study and the QUIRE study, both done in pre-dialysis patients, but I think their findings are relevant for the dialysis population as well. They're randomized to either low hemoglobin of around 10 to 11 or a high hemoglobin of over 13. And if you look at the CREATE study, you can see that there was absolutely no impact of a high hemoglobin versus a lower hemoglobin on cardiovascular endpoints. And similarly, if you look at the Choir study, which again was looking at non-dialysis CKD patients, what you actually saw was an increased risk of cardiovascular events in the higher hemoglobin group. And then there was a very important study, I think, which I think nailed this idea that correcting hemoglobin to normal levels with ESA was a good thing to do. This was a study in 4,000 diabetic patients, CKD, not on erythropoietin, and they were not on erythropoietin, obviously at the time of randomization, and then they were randomized to darbepoetin to achieve a hemoglobin of 13, and they got rescue therapy if their hemoglobin was less than 9. And the primary endpoint was death or a cardiovascular event. And when you look at all the different endpoints, you can see there's no difference in cardiovascular endpoints, no difference in death, no difference in non-fatal or fatal congestive heart failure, no significant difference in myocardial ischemia or fatal myocardial infarction. Interestingly, significantly higher risk of strokes with the darbepoetin group. And when you look at all the data, not only was there high risk of strokes, but there was also a high risk of death from cancer in those who had cancer at baseline. And what about quality of life? Because we all worry about quality of life. Well, they measured quality of life using various tests of exercise tolerance, and again, there was very little improvement in fatigue in those with a high hemoglobin group. Important to say that those people in the low hemoglobin group were still achieving hemoglobins of around 11 grams per deciliter, so still doing pretty well, and therefore the difference between achieving a hemoglobin of 11 and 13 is much more modest in terms of fatigue, tiredness, quality of life. So what about the future? Well, there are a number of different agents that are coming in, and I'm going to talk mainly about two. One group of agents are the HIF stabilizers. Another group of agents are Peginesatide, which are basically peptides that stimulate the erythropoietin receptor. Hepcidin modulators are, again, not yet in phase 3 studies, and there's talk about gene therapy, EPO gene therapy, and GATA2 inhibitors, again, not yet in phase 3 studies. So I'm going to focus mainly on these two. So as I said, Peginesatide is a peptide that stimulates the erythropoietin receptor, and there have been a number of studies, both in dialysis patients and in non-dialysis patients, summarised here, the Pearl 1, Pearl 2 studies, Emerald 1 and Emerald 2, showing them to be equally effective as erythropoietin. Now, one problem with this compound, which is why it may not take off, is that in one of the Pearl studies, there was an increased risk of cardiovascular endpoints in the group randomized to Peginesatide versus darbepoetin. Okay, so slightly higher risk of cardiovascular endpoints, statistically significantly higher risk of cardiovascular endpoints in that group. So that's raised some safety concerns about this molecule. So this molecule hasn't taken off in clinical practice as perhaps we thought it might have done a few years ago. What about the HIF stabilizers? So HIF stands for hypoxia-inducible factor. So hypoxia-inducible factor is a hypoxic sensor that upregulates EPO gene expression. Okay, so HIF is broken down by a prolyl hydroxylase enzyme, and so if you inhibit this enzyme, you increase the levels of HIF, which in turn upregulates EPO gene expression, which will in turn increase the hemoglobin levels in patients with CKD. It's a orally active enzyme inhibitor. The downside, we don't know yet for sure the downsides. Obviously it may impact on a number of other genes as well as EPO, so it may impact on other genes such as VEGF, and we don't know the the benefits or risks of that as yet. And there have been reports of severe liver toxicity, although I don't think these have been seen so far in the larger phase 2 and phase 3 studies. There are a number of phase 2 and phase 3 studies that have been planned, and there are a number of different inhibitors around, HIF stabilizers around. There's roxadustat, vadadustat, the GlaxoSmithKline compound daprodustat, and Bayer have got a compound called molidustat. Okay, and if you look at the literature in the last year, there have been a number of studies showing that these compounds corrected anemia both in dialysis patients and in non-dialysis patients, and they really correct anemia regardless of your baseline iron status, CRP, and they seem to be associated with reduced levels of hepcidin and increased endogenous EPO levels. So this may be a compound that perhaps is useful in patients with functional iron, these are maybe compounds that are perhaps useful in patients with functional iron deficiency. Okay, very briefly, I'm not going to talk about the KDIGO guidelines in detail, because if you go to the KDIGO website, you can look at them and there's no point in me just reading them out. But I'll just focus on a couple of key messages from the KDIGO guidelines. The key message the main message from the KDIGO guidelines to personalised therapy is to titrate the haemoglobin, move away from this idea of targets for everybody, but to titrate the haemoglobin according to individual response. So if a person is on dialysis and they have a haemoglobin of 10 but feel fine, you don't need to increase the haemoglobin. Similarly, if a person pre-dialysis has a haemoglobin of 11 and they feel fine, you don't need to do anything. So titrate the haemoglobin according to the patient's symptoms. So what does KDIGO recommend for the dialysis population? We suggest that ESA therapy is used to avoid having the haemoglobin level fall below 9 by starting ESA therapy when the haemoglobin is between 9 and 10. So really they're saying avoid less than 10, over 10, think a little bit about where you want to be. Individualisation of therapy is reasonable, as some patients may have improvements in quality of life at a higher haemoglobin concentration, and ESA therapy may be started above 10 grams per deciliter. Because of the QUIRE, CREATE, TREAT studies, but also importantly in the dialysis population, the normal hematocrit study, KDIGO have suggested that ESAs are not used to maintain a haemoglobin above 11.5 grams per deciliter in patients with CKD. That makes sense. And we recommend that ESA dosage adjustments be made on the basis of a patient's haemoglobin concentration, rate of change, and clinical circumstances. That's fairly obvious. And finally, important point here, practically, is they suggest reducing the dose if you want to reduce the haemoglobin rather than just withholding it. For those who are on ESA therapy but who aren't receiving iron, they suggest giving iron if an increase in haemoglobin concentration or a reduction in ESA dose is required, and there is evidence of iron deficiency, which they define as TSATs less than 30% and a ferritin less than 500. For adult CKD patients with anemia not on iron or ESA, we suggest a trial of IV iron only if you want to increase the haemoglobin without starting an ESA and you've got evidence of functional iron deficiency. Final thing about iron, avoid giving iron to patients with active systemic infections. And remember, when you're giving iron dextran, and the initial dose of non-iron dextran, make sure that patients are monitored for at least 1 hour after the infusion and that you have trained personnel available in case there is an adverse reaction. Obviously the ferritin, TSATs and iron studies are monitored every month in patients on dialysis. So to conclude, anemia is clearly multifactorial in patients with CKD. In practical terms, we should be individualising the anemia therapy to the individual patient on dialysis. We obviously want to optimise iron and haematinics, and we've got to be careful about using iron in patients on dialysis who have chronic infection and inflammation. The use of Hepcidin as a test in the future may help identify those people with iron functional iron deficiency, and the use of the HIF inhibitors in the future may be again useful for people with functional iron deficiency. You want to tackle the cause of marrow hyperresponsiveness, and that may be infection, infection, inflammation, or a high parathyroid hormone, all causing EPO resistance. And I think we have to recognise that in patients who've had a previous history of strokes or patients who've got cancer, we should be using the minimal, if we're going to use erythropoietin, we should be counting the patients of the risk and using the minimal dose possible. So that concludes my lecture. Thank you very much for your time and attention. I would recommend you do some of the MCQs related to this lecture, and I would also recommend, as I said before, you read some of the reading material that will attach to this lecture, and also the KDIGO guidelines.